Welcome back to the conference. Our team is thrilled to be here today. We were with you at the first one and coming back to bring you updates on our research. My name is Lisa Meeks. I am an associate professor of learning health sciences and family medicine at the University of Michigan. Go Blue. I am also the co-director alongside Dr. Justin Bullock of the Docs with Disabilities Initiative. I am not middle-aged anymore. I'm a little older than middle-aged, a blonde woman wearing tortoiseshell glasses with light skin. And it's my pleasure to be working with you today to bring you some updates on our research and the critical role of program access in UME and GME. The Docs with Disabilities Initiative is an umbrella organization that houses many of our different programs. And so I hope you will take some time to engage with our work. We are so blessed to be here with you today. And our newest program, just a quick shout out to the Access in Nursing program, which has just launched both the educational arm and the research arm. And then really quickly and on a serious note, we want to just make sure that we understand kind of what we're talking about here today. We believe, and by we, I mean collectively, our organization believes that all of the research findings that we will present to you today are indeed impacted by systemic oppression. This includes racism, homophobia, and ableism. This makes it unsafe, truly, for trainees and physicians to disclose their disabilities in some settings. And our findings in response must be viewed through this lens. So what does this mean? It means that our understanding of prevalence of this population is very likely underestimated. It also unfortunately means that reports of mistreatment and harm are likely underreported. I also want to give a big shout out to all of our team members, some of whom could not be here today. We are very proud of this robust team that come to the Docs with Disabilities umbrella from a number of institutions nationwide and across the globe. And here with us today will be many panelists, which will introduce themselves in a moment. But first, I want to acknowledge that our work collectively is not possible without the bravery of many medical trainees and physicians. And we want to truly thank you for disclosing on the myriad surveys and interviews and sharing your story. I mean this so truly. We are indebted to you. And because of you telling us that you identify as a person with a disability, our promise back in return is to work tirelessly to highlight and eradicate the barriers that you face in the learning, training, and practice environments. So with that, I'm going to turn it over to Riley Betchkel.
Hello, I'm Riley Betchkel, and I'm a master's student at Columbia University studying clinical psychology and also a research assistant for the Meeks Lab. I'm a white woman in my 20s with blonde hair and wearing a blue shirt.
Hi, I am Dr. Karina Pereira-Olma. I am a postdoctoral researcher at the University of Michigan. Go Blue. I am a Latin American woman in my 30s with light skin tone. My hair is dark brown, long and wavy. I'm dressed in a black V-neck sweater, wearing prescription glasses with a light brown frame.
Hello, everybody. My name is Chris Moreland. I am an internal medicine physician and professor and an interim chief for the Division of Hospital Medicine at Dell Medical School at the UT Austin. I'm a white man in his 40s with glasses. I'm wearing a dark blue button-down shirt. And behind me is a whiteboard with my daughter's art on it next to a bookcase.
Hi, everyone. My name is Zoe Sheets. I'm a resident physician in both internal medicine and pediatrics at the University of Chicago, as well as a member of the Meeks Lab and chair of the trainee committee underneath the Docs with Disabilities Initiative. I am a light-skinned person with brown hair that goes several inches past my shoulders, wearing a white sweater with a blurred background behind me.
So what is program access? Like before we start talking, we would like to make this concept, this construct, a common knowledge between us all. And in the last several years, our team has collected significant data on academic, professional, and mental health outcomes for medical learners with disabilities. And while doing this research, we have continuously found significant differences according to this critical construct that we named program access. Program access can be defined as having access to accommodations or not needing accommodations due to an environment where access needs are already met. So, if I need an accommodation and I have that accommodation, we can say I have program access. If I don't need any accommodation because my access needs are already met by the environment I'm in, we can also say that I have program access. However, if I need an accommodation and I don't have that accommodation, then I'm lacking program access. Before moving on with our presentation, we also needed to remember that while program access is extremely important, disability access is a construct that goes way beyond program access. Several barriers are not amenable to accommodation, including attitudinal barriers and barriers that learners face even prior to entering medical school. We are certainly going to talk about these barriers during the presentation, but before proceeding, we wanted to get us all on the same page on the specific meaning of what we are calling program access. With that said, we would like to present you to two learners, Adam and Frankie, depicted in the slide as a white medical student with black short hair and a black medical student with long curly hair in a ponytail. These learners are based on an amalgamation of real-life cases. Through telling their stories, we have an opportunity to share the barriers they experienced through the continuum, guided by research findings, and to provide an opportunity for you, our audience, to experience these barriers through their eyes.
To begin, allow me to introduce you to Adam. Adam excelled in undergrad, where he attended a state school and was provided reasonable accommodations, including a team of sign language interpreters, captioning for all video-based content, and recorded asynchronous coursework, labs, and school-related social clubs and activities. Despite attempting to gain considerable shadowing experience, Adam struggled to find a shadowing opportunity that would provide equal access via the accommodation of sign language interpreters. Once hospitals and doctors' offices found out that Adam was deaf, they flagged his application, preventing him from moving forward. Finally, Adam found a deaf health clinic and a deaf physician mentor. In this supportive environment, Adam thrived, and he learned a great deal. As a result, he received several letters of recommendation from physicians and administrators. He scored well on the MCAT in the 95th percentile, has a 3.9 grade point average, and along with his letters of recommendation, extensive extracurriculars, and a competitive undergraduate degree in molecular biology.
Adam, depicted here as a white male with glasses and short brown hair, enters the application cycle feeling positive, especially given the new focus on holistic admissions where he felt his disability would be valued, both as a distance traveled element and the value of his lived experience of disability and barriers navigating the medical system. Ultimately, he applies to 10 schools and received interviews for 6. Immediately after receiving the invitations to interview, Adam reached out to the schools and requested a sign language interpreter for his interview. 2 of the schools schedule an interpreter and tell him not to worry, that all the items have been taken care of. 2 schools send him a copy of the technical standards and ask if he can meet the standards, noting that an intermediary of any kind is not permitted. 1 school responded that they've never had this situation and are unsure of how they implement this, that they need to get back to him. asking him if he has an interpreter or friend or parent he might use in the process. One school never responds. Adam struggles to have access to the admission process or program access as he navigates his road through admissions.
Unfortunately, admissions barriers, including lack of program access in the interview process, biased belief systems about the ability of deaf and hard of hearing individuals to be physicians, and barriers during the pre-med process, including difficulty finding shadowing, keep the number of deaf and hard of hearing medical students low. These numbers have significantly declined from 2021 at 3.2% to 2022 at 2.4%, as shown in the blue bar on the slide, and they have not bounced back since. This is in stark contrast to the upward and consistent growth of students with disabilities overall, as shown by the yellow bar on the screen, which includes self-reported data rising from 12.9 to 15.6%. Adam eventually matriculates to a school and is welcomed, but he feels a bit of hesitation from the administration. An image on the screen includes an animated Adam conversing with an animated administrator, and he senses tension when he converses with them about his disability needs. The accommodation process is not discussed with his class during orientation or at the beginning of their coursework. There is no specialized DRP in the medical school, represented on the slide by an image of a man working on his laptop with a large no symbol, a circle with a line through it, over him. Adam is instead sent to the main campus disability office. His disability representative is transparent with Adam, sharing that he knows almost nothing about medical education, and he asks Adam to determine the needed accommodations. Adam naturally asks for a sign language interpreter and captioning for all of his coursework and any clinical experiences based on his previous educational experiences.
This slide depicts a photo of a computer with captioning and the number 25% in gold above it. The disconnect between the main campus and the medical school results in the medical school activating automatic Zoom captions for Adam's lectures. Unfortunately, Zoom does not sufficiently meet his needs. He utilizes the Zoom captions, but about 25% of the material is illegible, and many concepts and medical terms are incorrectly spelled or presented. As a result, Adam finds himself working twice as hard to reread materials after the lectures to ensure understanding of the concepts. Adam finds himself without good choices. He doesn't want to complain, but also has little confidence that the system of support works efficiently. He is unsure who to turn to help navigate the options. The need to review all the material for accuracy takes time, as depicted by a stopwatch. And as a result, Adam misses out on social activities, like this icon that shows a group of friends. At first, he can maintain his sleep, but eventually, as the curriculum ramps up, Adam struggles to find time for all his work and begins sacrificing sleep for study. He also quits exercising. This is shown with a moon with the Z signs across it and a figure working out.
The lack of sleep and absence of social structures begins to take its toll. In the slide, we have a character photo of a male in blue sitting and lowering his head with a cloud that shows a person's shadow with a web of circles in the brain. Adam feels conflicted about reaching out to his school, knowing that the disability representative doesn't understand medical education. He also doesn't want to seem needy. Adam feels lucky to have been accepted to medical school and decided to forge ahead. By winter break, Adam is experiencing significant depressive symptoms. We know that learners who lack program access have a significantly higher increase in depressive symptoms, as depicted in the slide by a yellow stanchion next to a female sitting on the ground with lots of hands coming out to represent her feeling depressed. Unfortunately, we are also aware that learners with disabilities are more likely to experience burnout when compared to their peers. Having program access reduces the likelihood of burnout and increased depressive symptoms, which should be a major goal for all schools.
This slide shows a medical professional hanging an IV bag with a resting patient next to them, both masked. A large exclamation point warning sign is next to them. Beyond learner well-being, program access affects patient care. Learners that report not receiving necessary accommodations are far more likely to report medical errors, a finding that does not hold true for learners who do receive accommodations. For Adam, fortunately, entering the clinical experience was a reprieve. An animated Adam is again on this slide with two hands signing pictured next to him. The shift in didactic to clinical environment triggered an automatic reevaluation of accommodation needs. And although the DRP was not well versed in clinical education, the need for a sign language interpreter was clear. The school hired a designated interpreting team with a clear understanding of clinical culture and advanced sign language skills for medical terms. They were familiar with this clinical setting and did some education with the clerkship directors and coordinators. This advanced educational approach made the process smooth. With the addition of medically trained sign language interpreting teams, Adam thrived. Unfortunately, though, each week his didactics and grand rounds continued to serve as a barrier, using Zoom captioning and having to fill in the pieces where the captioning was incorrect or just missing. But he thrived with the patients. Indeed, the patients loved him. Adam earned the respect of the faculty and connected so well with those around him. His communication skills were evaluated as excellent. Adam winds up matching into pediatrics in a community hospital that serves a number of deaf patients. He is shown on this slide, auscultating the heart of an adolescent patient. He is thrilled with his choice, but he wishes medical school had not had so many barriers.
In addition to the quantitative data, as well as the anecdotal stories, we were able to collect qualitative data from our newest AAMC study. Now, what did we learn? What did learners tell us about their experiences gaining program access? Let's find out. On the slide, there was one direct quote. It says, "It has been difficult connecting with our main campus staff for accommodations." Here we see a slide with another quote. It says, "My accommodations are routinely ignored and not uniformly enforced among instructors. I stopped advocating for them to be enforced because it took too much of my time and energy." Learners would tell us repeatedly that they did not have access. However, the stories look different when the program access is available. So let's see what learners have to say about program access being available. Faculty encouraged me to seek accommodations for my disability, even though I hadn't. The students' disability services were incredibly helpful and responsive. It's even more meaningful when learners couldn't quite bring themselves to request accommodations, but were encouraged to do so by faculty. The quote on the slide reads, "My medical school has been very proactive so far about supporting me with my medical education in whatever way they can." Beneath that is another quote that says, "Disability services offices have been very accommodating and easy to work with."
Now let's take a look on another learner as they navigate medical training. Meet Frankie, depicted in the slide as a person with long curly hair and dark skin, wearing a white coat with a stethoscope draped over their shoulders. Frankie, unlike Adam, enters medical school with a non-apparent disability. Learners with non-apparent disabilities must decide whether or not to disclose their disability to the program in order to receive accommodations. More than half of intern physicians with reported need for accommodations do not request them. Here we have a character picture of Frankie with their index finger raised to point out that the most frequently reported reasons for not requesting needed accommodations are fear of stigma or bias, lack of a clear institutional process for requesting accommodation, and lack of a documentation. Indeed, trainees with disabilities tell us about the fear they face navigating medical training with a disability. We highly recommend reading the JAMA Network Open Invited Commentary by Ro O'Reilly and Salas, which are pictured in the slide with the title, Stigma Associated with Requesting Accommodation, the High Cost of Ableism in Medicine. Back to our story. Fortunately, Frankie enters medicine well prepared to ask for and implement necessary accommodation. They are depicted in the slide smiling while wearing a white coat with a stethoscope draped over their shoulders. Frankie was diagnosed with ADHD as a child and has been seeing the same psychiatrist for years, excelling in school. Indeed, they were accepted into an Ivy League medical school. Getting accommodations was not difficult. A part-time learning specialist handles accommodations and required very little documentation from Frankie, only a signed form from their provider. With accommodations, Frank thrived in medical school, having additional time on didactic exams and not really requiring anything on the awards.
Now, as Frankie prepares to take step 1, they reach out to the learning specialists and they simply complete the proof of prior accommodation signature form from the NBME. Frankie sends the letter anticipating a short turnaround. To their shock, though, 60 days later, Frankie receives a rejection letter stating that because they performed in the top 10% of all MCAT takers and were accepted to a competitive Ivy League school, that this is proof that they are not functionally limited compared to the average person standard. Frankie believed, with a strong history of accommodations and a lifelong disability diagnosed in childhood, that they didn't need a lot of documentation. They reached out to the learning specialist early, completed the forms. Upon review, however, the psychiatrist's letter was not detailed enough. Because of the complexity and nuance of the NBME accommodations process, extensive planning and a letter of support from a specialized disability resource provider are necessary for many students to be successful. The more typical pro forma letter that a learning specialist might write for other educational situations is often not sufficient. Frankie is terrified by the thought of taking the exam without accommodation, but doesn't know what else to do since they are on a short timeline. An appeal requires extensive new evidence and several more months of review.
So what do the data tell us? This slide shows the pathway in graphic form that learners take when they are not accommodated on the USMLE Step 1 exam. Indeed, in this study in +1, 52% of applicants for the data that we had were denied accommodation. Many of them delayed their entry into the clinical phase of training, but 76% took the step exam unaccommodated. Of those, 1 in 3 failed the exam, and ultimately 4% of these learners left medical training. Student stories add layers to the quantitative data, helping us understand their experiences in more depth. For example, this student states that they have access with the exception of the items that are outside of their school's control. They say, "My school has done a good job meeting my accommodations. I wish there was more support with applications for licensing exam accommodations or workplace accommodations." This student questions whether the USMLE will acknowledge their disability. In their words, "My medical school has been overwhelmingly helpful when it comes to managing my ADD. Testing accommodations for block exams, quizzes, tutors, and free psychological counseling are some of the resources I use all the time. The only time I felt disadvantaged is with standardized testing, the NBME, the USMLE, because they don't recognize ADD as a disability that warrants extra time, despite my neuropsychological evaluation, testing, and documents from other health providers."
This slide shows an image of letters spelling out LOA with a characterized head and several different pathways showing in the space where the brain exists. So Frankie takes the exam and gets a no pass. They are forced to take a leave of absence to go through the appeal process and to re-prepare for the exam. Research shows that this is common for students with cognitive-based disabilities and that this denial can lead to a delay in graduation. On top of that, being on leave of absence will also impact access to student health services and the loss of their peer groups. Frankie must now scramble to find research or a special project to complete during this time needed to appeal the NBME decision. Frankie finds himself in limbo. There are additional risks for Frankie. A recent study led by Nguyen and Meeks found that underrepresented medical students with disabilities have a 30% higher risk of being burnt out compared to their non-URIM peers. This slide contains a drawing of 5 medical students with dark skin and blue scrubs and white coats. Unfortunately, a very new paper that came out last week, led by the same combo of Nguyen and Meeks, showed that students with disabilities are less likely to match into some specialties. This was most prevalent for surgery. On the screen is a photo of this new article in JAMA titled Outcomes of the Residency Match for Applicants with Disabilities.
For both Adam and Frankie, heading into practice won't necessarily provide them with the protections they seek. Indeed, a 2022 study by Meeks et al. Demonstrated that physicians with disabilities in practice are more likely to experience mistreatment and harm, while a paper coming out in a week or so shows that physicians with disabilities are more likely to experience some elements of burnout. This slide shows several stick people, with one shouting at another and a third sitting in a ball, appearing dejected. As we close our talk, I hope you can see just how impactful program access is in medical training, and this continues to hold in practice. In a paper led by myself coming out soon, we show that physicians with disabilities who do not have program access are more likely to report an intent to leave the workforce. We see several members of this workforce on the slide, with 4 animated physicians of varying skin tones, all masked and waving hello. We can and must do better by our trainees and our clinicians.
Thank you, Zoe, and thank you all. Today, we attempted to share our latest research, specifically highlighting the critical role of program access. And we hope that this is helpful for you in contextualizing what our learners and trainees are going through, and also what our physicians still face in practice. We encourage you to engage with some of our resources, including our communities of practice, DIGME, which is focused on the graduate medical education context, and AIM, which is focused exclusively on medical schools. We also invite everyone on this talk to join the AAMC Disability Inclusion community. And you can do that through the URL shown on the screen or the QR code. These are both also in the Word document we've provided for access. The Docs with Disabilities Initiative shares all of our resources and our new research through all of its social media, including Twitter, I refuse to call it X, our YouTube channel, the Docs with Disabilities website, and Instagram. And recently, we've opened up a LinkedIn profile as well. Most importantly, as you navigate this work and as we all work together to improve disability access, we ask that people remain curious instead of being judgmental about what it means to be a clinician with a disability. And we are so happy to have plenty of time to answer all of your questions. So go ahead and put those in the Slido. Let's see. So here's one that is, I think, really interesting, and it's a misnomer that people have all the time. Here, an anonymous person has posted, I was told by my instructor that she wouldn't accommodate me in the class because the workplace wouldn't accommodate me when I'm done with the program. Does anyone want to speak to Title I of the ADA and how it covers workplace accommodations? Okay, I will. So the ADA covers both the educational context and the workplace, and it covers the workplace under Title I. And so actually you are eligible for accommodations in the quote unquote real world. And we encourage you to engage with whatever process is in place for learners or physicians or any clinician to go ahead and request accommodations. I think the big difference here is that the workplace is less prepared to accommodate learners than the educational space. And the educational space isn't always aware of the legal obligation in employment settings to accommodate the trainee or the provider clinician. So it's definitely something that's covered. So there's another question about how I can get ready to request accommodations and take these high stakes exams. What resources are available? Does anybody want to talk about those resources?
I think at least one that I'll highlight, and I know that others are familiar with some as well, is MSDCI is a national group of medical students with disabilities and chronic illness who are heavily engaged in this conference, and the founder spoke at the beginning as well. They have documents that are compiled from the learner experience as well, of things that have worked and not worked so well. And while I obviously encourage folks to work with their DRP, I also recognize that as evidenced by Adam's story, which is rooted in so many others' lived experience, DRPs may not always know the ins and outs of these types of nuanced applications. And so I think it's actually a major strength of the community of medical students with disabilities to share not just what they've learned through lived experience, but when some of us have the privilege of having DRPs that do very much understand this process, the tips and resources and documents that have been shared with those students often get shared through the network of medical students with disabilities and chronic illness. So I just wanted to highlight the not just the guide that they have, but simply the, sort of connection that they are and community they provide to ask these questions and troubleshoot these types of things.
Great. And there are actually resources available on our YouTube page. I'm trying to put those in now. I'm a little wonky with Slack and I do apologize, but there's a 3-part webinar series that you can access for free. And as well, there is an NBME guide that our amazing DRPs have created that is really helpful. It's designed for DRPs and for learners to utilize as a resource. So sending that in the Slack right now. And then finally, if you're not aware of this already, our book, Equal Access, the Guide for Disability Inclusion in Health Professions Education, is now available for free. We were able to get the copyright back so that we could make it available to everyone at no cost, because unfortunately we saw lots of disparate access to the book based on resources at different schools. So we wanted to make sure that everyone who wanted to read it had access to it, and that includes the learner. So I've put some resources in Slack. I assume if somebody could just confirm for me, that's where we want these to go. And perhaps we can do a subtype called resources, because it seems like lots of people are sharing resources. So here's a great question. How can students and trainees constructively help their institutions advance towards accountability and disability equity when when there's pervasive ADA disability rights violations? So how do you get a foothold or a little bit of traction in that space? And maybe Chris and Zoe, this would be a question most pointed to you.
Sure. Thank you, Lisa. I'm happy to comment on this. And that is a key question. The act of advancing institutional adaptation to disability inclusion requires an all-hands-on-deck approach from administrators and educators, as well as the learners. So first, I would like to say that I recognize asking learners and people with disabilities, including employees, faculty, and staff, to take on that extra work, oftentimes that is in addition to the work that they're already doing. So I consider that balance carefully. Now, to come back to the question about learners and how they can activate their institution, I think it's important to recognize first that their voice matters. Speaking up is helpful if you feel safe to do so at your institution. I would encourage people to find allies within the organization, people who might be interested in sponsoring you or somebody into that role to help develop access policies, adapting technical standards for the medical school, and other policy advancement. You might also identify people within the disability community who are outside of the institution, invite them into the organization, for example, in grand rounds settings, or as consultants in other ways to bring their expertise and their lived experiences. Again, Zoe, Lisa, and others have already emphasized the importance of national peer and other mentor networks. So I would encourage people to use those for ideas as well.
Zoe?
Chris said it so well and highlighted some of the things that I always share when I'm asked this question. I think the reality is that it should never be the responsibility of those of us who need the access to be doing all of the fighting for the access. Unfortunately, I think we are also not at the stage yet where access is a universally understood requirement in medical education and practice. And so sometimes we do wind up in those situations, and we do have to advocate for ourselves to make sure we can advance in our career and care for the patients that, as evidenced in Adam's story, we can care for so well. To do that, I wholeheartedly agree with Chris, and I'm incredibly grateful to have Chris as a mentor who has provided this for me. But we have to have people who have come before us to help us pave the way and to pick us up when the system makes us feel like we've fallen down. I think sometimes it's hard to find those connections. Dr. Kessler talked earlier today about how for so long she felt so disconnected, and I felt the exact same way when I entered medicine, lonely and a little bit helpless, like I didn't really know what I should be doing next to get the access I needed. So I also just want to remind folks, if there is not someone who is right now easily accessible to you, the thing that initially gave me the courage I needed was actually the Docs with Disabilities podcast, because at any time of day, whether I'm walking to the hospital and trying to get brave before I go in, or if it's been a really hard day and I've experienced some ableism, that's a place where I can find stories that make me realize I'm very not alone in the hard experiences, and also very not alone in the joy of being a disabled doctor. So find your people, plug in, find your community. The other thing I will say is sometimes administrators are truly a little bit clueless when it comes to disability, even if they are incredibly kind and well-intentioned people. I'm preaching to the choir here, but disability has not been at the forefront of conversation in medicine in the way that it always should have been. More so now than ever, but still not at a level it needs to be. And so it is frustrating and unfair to be the recipient of that. And I found it incredibly helpful when I'm talking to leaders in my programs to invite them to collaborate with me to address that. I think that sometimes when we enter those meetings feeling so frustrated, we can feel very accusatory. And although sometimes it's warranted, we also have to be mindful that the only way the program will get better is if we work together, teach what we know, and teach through our lived experience so that it can get better for the next person who's coming, and hopefully get better for us for what we need right now as well.
Wonderful. Well, there are comments about how we did an uncanny job of getting the lived experience kind of summarized in these two cases. What we really wanted to present to you was the the disparate experiences learners are having and the disparate experiences they're having even within one learner's journey. It's not that I think there's a very clear disconnect that some learners are having amazing experiences at some medical schools. Other learners are having really poor experiences at medical schools. But even within the learner to learner story, so within the individual learner, they are having both good and bad experiences that we have then it created this idea of, are they having program access or not having program access? And this can be going across different areas. As you saw, for Frankie, especially, Frankie was swimming along, having a wonderful experience and performing really well. And it was only when they hit the barrier of program access to the step 1 exam that everything started to unravel. And you can see how for a learner, when that happens, it not only impacts their time to graduation, it impacts so much of their social life and their financial impacts as well. So we can't stop advocating and we can't stop working on improving policies because we have a long way to go, even where there are situations where people are doing really well. One question, Karina, that I wanted to address with you was really looking at mental health related disabilities. And of course, in this particular, these two scenarios for Adam and Frankie, we've chosen deaf and hard of hearing, especially because we've seen a decline in that population. So we really wanted to highlight the barriers because especially for this population, once the admission barriers are removed, they perform, excel, in all areas. So there are no performance differences or time to graduation differences that we see. However, with those with cognitive disabilities, including psychological disabilities, we do see some differences. And while our specific our specific cases did not address a psychological disability, there is a question in the chat about whether or not people with psychological disabilities are disclosing and what's happening there. Do you want to speak just really broadly about what our research has found? Because we do collect this data. We actually collect the most data about students with psychological disabilities.
Sure. No, I would love to comment on that. Unfortunately, what we see is that there are differences in disclosure and requesting for accommodations for people with cognitive disabilities. And when I say cognitive disabilities, this is a thematic category that we created that includes psychological disabilities, ADHD, learning disabilities, and neuropsychiatric disabilities. And people with this category of disabilities, when they are compared to their colleagues with physical, motor disabilities, sensory disabilities, or chronic health issues, they are less likely to request accommodations when they need accommodations. We see that the stigma towards psychological disabilities seems to play a big role on that, because among the reasons that they give us to not request accommodations when they need those accommodations, the top reason, more than 60% of them report that the main reason is a fear of stigma or bias towards them. So they prefer not to disclose accommodations that they may need because of that. And we see that both like in the medical school, we also see some board exams for some states, for example, asking questions about history of mental health, which of course can cause a fear to disclose those. And this does like seem to be something that is putting a barrier for those students to progress. Among disabled students, those with cognitive disabilities are the ones where we see like the higher impact on time to graduate, on scores on exams. But what we also see is that when they have access to accommodations they need, or if they are in an environment with universal design where they don't need accommodations because that environment is already meeting their needs, those students tend to thrive, and they tend to not show differences between their other colleagues with disabilities or their colleagues without disabilities. So that's definitely a group of students that we do need to pay a special attention and to fight together to reduce the stigma towards that type of disability for sure.
And I would add that this is where, I think the sharing of stories is so important for any disability category. And Zoe spoke to the power of the podcast and listening to those stories. Listening to the stories of individuals with mental health related disabilities and seeing them continue to thrive in clinical spaces, I think is really, really important. Our co-director of the Docs with Disabilities program, Dr. Justin Bullock, speaks very frequently and very openly about living with bipolar disorder. And I think, we often have these very long philosophical conversations about the number, not only of lives that he's impacted and perhaps saved by being vocal and being an advocate in this space, but the number of people that are in powerful positions and training spaces that will change their perception of what it means to live with a psychological disability because of hearing these stories. And of course, Justin's not the only one. We have several individuals who have spoken about this. And then I think I would be remiss if I didn't mention that I think and I think we could actually show this. I think we're moving towards being able to show this, that individuals will come into our training spaces with one category of disability, whether that be a learning disability, ADHD, being deaf and hard of hearing, or low vision, or a mobility disability, and will develop a secondary disability of a mental health disorder, depression, anxiety, as a result of the way that the learning environment has engaged them on their primary disability. And so I think we can't underscore enough how important it is to create safe training environments and to have educated, informed, trained disability resource professionals. I hope you noticed that a theme through both of these cases was indeed the lack of a specialized disability resource professional, which is a consideration in the AAMC report, but a recommendation in the AMA report from 2021. This is really vital to being able to be connected to the resources, to understanding the ebb and flow and needs of a medical trainee. I think this is one area where there's a lot of improvement in front of us, and we're really excited about the potential to both train these individuals through our DRP Academy, but also to place them. Last year, we helped facilitate multiple jobs for individuals in these specialized roles. And I want to just give a really big shout out to the California system, to the University of California system in particular, and to Stanford, who in the last year have committed to bringing on a specialized DRP. And that will do a lot for those spaces. It will undoubtedly make room for people to become specialized, but I think it also lowers the caseload of each DRP, disability resource professional. And when you lower that caseload to a manageable amount, then the DRP is able to work proactively with the learner and the trainee in these spaces to be able to operationalize some of these things that we know are going to happen across different disability types. And if you're looking for information on this, as I said, the UCs have all done this. Stanford recently hired someone. UIC recently hired someone. So there are multiple institutions who are now working under this model.
And Misa, if I may, I'd like to make a comment. In the last few minutes, I think that we have implicitly highlighted the diversity of disabilities in our conversations in the community. We see the diversity of disabilities in the event today. Given that range of experiences and accommodations and needs within each disability group, and as you said, with people who experience more than one disability at some point in their life, I think that's where the stories become even more powerful and help us to enrich the quantitative data by using stories to highlight the nuanced experiences that people have.
Yeah. Thank you. I just want to note there was a comment about cognitive disabilities and how we've lumped together some subcategories of disability. That was done to get enough power. And that was a decisions analytically that was really driven by what we were working with, the data we were working with. I'm really proud to say at this point we have, because we have multiple years of now AAMC data, we'll be able to analyze across actual individual categories, and that will be lovely. And then we just completed data collection on our Pathways 2 program, which is in addition to the Pathways 1 that we're kind of reporting out some of those findings. And we will also be able to look not only more specifically at category of disability and drill down, if you will, but we'll also be able to look at important things like characteristics, demographics that we had not been able to look at previously to see if there are indeed more barriers in place for individuals at the intersections of specific identities, which we are hypothesizing that there are, of course. So let's see, what other questions? Someone asked about the 2021 AMA report, and I will find that link and put it in. And so here's a great question that just popped up. Something I often see overlooked is chronic pain and illness. Absolutely. The biggest barrier for individuals with those conditions can be the grind culture. We agree. And the long hours of medical trainees and training and accommodations don't always help unless it's a reduction of hours. What steps can we take to not exclude these? So I will say one thing, and then I'm going to turn it over to Zoe, who I'm sure is like ready at the to answer this. But as a person with a chronic illness, myself, pain is one of the symptoms that I'm constantly grappling with, and it is very, very difficult because I do think, for me at least, I'll just say for me, it can result in the inability to pay attention. It can result in the inability to be mobile. It can result in being very, very tired just from the cognitive energy that I expend on a daily basis. I think we are capturing this. I think we're just capturing it in other ways. So I would say that we are probably capturing it through that chronic illness category or chronic health category that we have. And then we always have an other category. So although we've talked about the 5 categories that we have, when we report our data, we do have an other category. Here's where we catch things like stuttering, TBI, we catch amputees, and often people will talk about having chronic pain as well. So those numbers, when people are talking about in isolation, are very low. But as we collect more data, and again, this is just one more opportunity to say thank you to everyone who reports on these surveys. We can promise you from our end, as the people who are writing and signing the data licensing agreements, your data is very private and is held in the strictest of confidence by the AAMC and other organizations. We are very limited into what we can get, and they're very protective of that student data. So please know that. I hope that gives you some sense of relief. But as that data comes to us, we will analyze it and pay attention to it and report on it. We are committed to doing this. So Zoe, I'm sure you have some things to add.
Yeah, I know we're really close to, if not just over time, but I live with a chronic pain disability, chronic pain, chronic fatigue, and some mobility limitations as a result of a house fire when I was younger. And this is forever my question and frustration with our system. So first of all, I hear you that this feels like an impossible thing to change, because it is simply the entirety of medical culture is the antithesis of disability culture. And I echo that feels, like perhaps an insurmountable thing to change, but I don't believe that it actually is. The few things I'll quickly say is I think a critical part of this is redefining what we think of when we think of accommodations. I think people who kind of swim in these waters note that accommodations means a million different things. Really anything that can diminish a barrier for a student is an accommodation. But unfortunately, I think that sometimes folks who don't kind of swim in these waters as often as we do, they really think of accommodations being things like ramps or stools or sign language interpreters, whereas sometimes we need a little bit more creativity for the things that go against the simple structure of a day in the life of a medical student. Some things I'll highlight that have worked really well for me are things like having a scheduled break every day as an accommodation and knowing that I can tell my senior or whomever that this is the time I have to step away and my pager needs held by someone else or someone else needs to have my phone. Things like asking to not work overnight shifts, which I sometimes do, but sometimes don't. I kind of listen to my body and navigate it as it comes up. Things like when I'm on a 24-hour call, making sure that I ahead of time set reminders on my phone for when I will be stepping away to do physical therapy stretches. These are all accommodations, and some of them are things that I simply do for myself, and some are formally provided. But I've found that as long as I am honest with my team from the get-go, my fellow trainees understand that we are all going to have needs sometimes. And when they show up for me like this, I'm going to show up for them at some point as well. I think sort of the second thing that I just want to leave us with is medical culture will only change if people are vocal about the ways it needs to change, right? The inflexibility and the high time demands, the frequency with which we have to swallow really intense emotions because we see really intense things, these all exacerbate disability and they all lessen accessibility. As those of us who understand that progress in our medical training, I think things will naturally start to change a little bit. But for now, it's our job collectively as a community to be as vocal as we possibly can about what an imagined future could look like. What is the alternative? So that it feels feasible, it feels reachable. We know what we need, but we have to show people this is what it could actually look like.
Thank you all so much. Thank you to the amazing panel and to all the people who work with us on our research team. And thank you, Peter Poulos, for giving us the opportunity to share our latest research.
Thanks, everyone. That was wonderful.